Now, our next session is going to try to answer a very challenging but critical question. When making treatment decisions together, what should guide our choices? And how can patients identify what matters most to them? This is something I think about almost daily in the emergency room. Even for something as seemingly trivial as a minor fracture, we have treatment options, and what decides what treatment the patient chooses varies from case to case. So this will be all the more important for lung cancer. Now, to help us answer this, we are joined by Jens Ulrich Rüffer from the Share to Care Patient-Centered Care Program. He's also head of department at the Deutsche Fatigue Gesellschaft, which is an association dedicated to research, diagnosing, and treating cancer-related fatigue. At the end of his presentation, we will be having some questions as well, and it's going to be engaging in person and on Slido, but we will favor engagement in person in this session, so do get ready for that. Now, with that said, I'd like to welcome Jens on stage. Please warmly welcome him.
Thank you so much for this introduction and also for this hymn already played before I started. That's not normal. Okay, thank you very much. It's a great honor here to speak on your first conference, and it's especially giving me the opportunity to speak on my very, very hardly topic I'm following now since 20 years. As you already mentioned, that is all about communication, shared decision making, what we are talking about, and it seems to be that it should be normal. It should be normal, you said, in the emergency ward, it should be normal in every daily practice. But what we have to be aware is that it is not normal, that it is not standard procedure, it is not standard care, not only not in oncology. Oh, there's something wrong at it, okay. I can't ignore you. How should I do? Nobody should ignore anybody. So as it is all about communication, I just have to admit that we have a little intermingling in the beginning, because I understood from the briefing that I should just set the scene with 10 minutes and then we have a discussion. So I depend on you as an audience, as speakers always depending on audience, to interrupt me whenever you want, to have a lively discussion and just go on. I think I'm ready to answer every question while I'm talking and especially after I've talked. Well, what I'm going to do with you is right now going through an agenda saying what is SDM, what is shared decision making. Of course, there are many definitions, but I think it is very important to be aware that this is a process which can be done in every medical situation. Then, of course, the question is, why isn't it routine setting? Why is it part of daily practice caring? And taking a look in the literature, looking for the pros and cons of SDM, and are there any cons, you might ask? And then there are more specialized focusing topics are like health literacy and SDM. What is the difference? Is it adequate, what some doctors maintain? And finally, is SDM a question of education? And I think there is a very interesting answer to that. And doctors always saying, well, shared decision making is a very nice topic. I love to do though, but patient asked me to decide for them. And I think this is always an argument against implementing the process of shared decision making. And I'm not quite sure whether this is the right attitude. And finally, there is no alternative to that SDM becomes standard care. And I hope then that you will agree after this talk with me. Finally, I have some conclusions and the perspectives. Definition of SDM. Of course, it is just simply making decision together with your doctor, with the healthcare practitioners. And that is not routinely care, that is not standard right now, because what is missing is that these decisions are made by best available evidence, saying what are the benefits, what are the harms of every option. If you talk to patients after a decision talk, not seldom they say, well, I don't know what we are really talking about. I haven't really recognized that there was also already taken a decision. And of course, the question is, does SDM make sense in any talk, in any decision talk? I'm very strict. I say it is always senseful, but some of my colleagues say it is only senseful if it's a clinical equipoise. That means that treatment is somehow comparable. I think if you have one treatment option, you have always the option to have no treatment, to say, no, I don't want to have treatment. I'm just caring about a patient. She has suffering. Just yesterday, she got the diagnosis of metastasis in the cerebrum. And of course, there's a question, this is an MRI diagnosis. Should we go on with radiation or not? And if you ask doctors, they will say, yes, go on with radiation right now. But if you talk to the patient says, I'm an author, I'm a publisher, I have to work with books. If I go on radiation right now, it is hard for me because my plans are different. And then the doctors, if they don't take these values and this trade-off into account, then this treatment would start and she wouldn't be able to follow her work. Notice, please, at that point that she's not suffering from any symptoms. It was just a diagnosis of MRI. So that is what we have to talk about value clarification, about trade-offs, which are with every person different. And that makes it so important to make shared decision-making, to take all these values of patient into account when you make decisions. If you look at this topic and then you would say, well, this is normal. If I go out buying a car, if I go out buying a skirt, then of course I want to know which kind of skirts are there. What are the benefits? What are the disadvantages? Is it blue? Is it red? Whatever. That is even more important in clinical settings, and therefore everybody would say, yeah, that should be a part of clinical routine every day. That it shouldn't be only wishful thinking. But if you then, what I did, I asked ChatGPT, I asked, please, can you draw me a map of Europe where every spot is marked where SDM is part of daily routine care. And that is the answer. Creating such a map is not feasible, at least not in the sense of all places where SDM is standard practice. The reason is important to understand. SDM is almost nowhere in Europe a widespread standard practice, but it's mostly politically recommended. And every guideline, in Germany, I'm part of some guideline groups, and everywhere in the last part of the guideline, of course, when everybody has already stopped reading, in the last part of the guideline, they're standing, and please use shared decision-making procedures to discuss with your patient the different options. But even guidelines is a kind of a difficulty for patients, because every doctor is, if he knows the guideline, he's trying to work along the guideline. Doctors sometimes misunderstand this topic. They think if the guideline says you have to do this, then my task is to convince the patient. It is not to discuss whether he can do option A or option B. So guidelines are sometimes not only helpful for the SDM process. And as it is said, it is implemented in pilot projects in individual clinics or programs, as we have done that in Kiel, a city in northern Germany. But it's not established system-wide. What is the reason for that? Is it because there's evidence, lack of evidence? Do we don't believe in shared decision-making? I'm the only one who believe in? I'm not quite sure. I have some friends who also believing as them, so I hope that we are not the only ones. But if you take a look in the literature, looking for pros and cons against shared decision-making, then is that what you find. The evidence is very robust for knowledge. That means if you apply shared decision-making, the knowledge of the patient will increase and significantly increase. That is absolutely safe. What is also safe is that decision quality is increasing. Patient make better decision. And And that is not only true for the patients, that's also true for all members of this process, also for nurses, also for doctors. They are more satisfied. Later on, I will reflect on our results we had from the University of Kiel, and it is even more understandable. The evidence is moderate for adherence. Of course, it is very important. As you may know, in different diseases, there is a problem with oral intake, as it is also in in lung cancer. Patient, for example, in breast cancer with anti-hormonal therapy, that only about 50% of the patients are adherent to this therapy. So with shared decision making, there is a pretty good proof that these numbers will increase. Care decision will be better, and of course what is difficult is hard clinical outcomes. Do they improve? I'm totally convinced that they will improve it if adherence is going to become better. Then in the end, if the diagnosis is correct, if the treatment is correct, then the outcomes have to be better. So hard clinical outcomes, that means quality of life, that means morbidity and mortality. This is of course a very hard standard which is given by the health insurance companies. These are the pros, but we have also some cons. We know that if people are facing shared decision making, if they are facing that they are now part of the responsible team, which is a good thing, but that makes you nervous. If you're first time being confronted, taking over responsibility, being part of the group who making choices. For some people it increases anxiety, for some people it makes a kind of a decisional burden and responsibility stress. The good news is that is in the beginning. After a while, oh, that's not me calling. After a while, it is falling below the starting point. So even these cons are not explaining why this is not standard routine care, making STM process a reality in the society, in the medical society. Well, some of my colleagues, some of the discussion parts saying, well, STM, that is like health literacy. They're talking about health literacy. As you might know, that is a very important, that's an urgent call. Just do it. This yes, I don't know what to say anymore. Okay, we come back to the health literacy. Health literacy is, of course, important. We can say that is something which makes it for patients easier to be part of the whole thing. But to reduce it to health literacy means we as a doctor, we as a healthcare professionals, we are not part of this process. And that is totally wrong. That puts the burden totally on the shoulders of the patient if it adequate STM and health literacy. In reality, STM is a process between doctors and patients. And what is very important to understand, patients getting by chance a diagnosis. Doctors can be prepared on this role. They have to be trained in shared decision making. Otherwise, it is only wishful thinking. In Germany, we have this nice expression, if it would come from wollen, it wäre Wunst, and if it comes from können, it is Kunst. Nicole is laughing because she understands that, and she has to translate it later. But, but of course, this is especially a thing which is in Germany really hard to discuss with doctors. And even we have organized trainings, we have proved them, we have randomized control trials on this training, and all in all, it's only 4 hours. 4 hours in the life of a doctor, which is normally longer than 4 hours. It is 1 hour online training and 2 presence trainings, nothing else. And after that, we can double the competency to make STM, competence to make STM. And on the meso level, this is a process for the institutions. Institutions have to decide whether they implement shared decision-making in their context of caring for patients. In Germany, we talk not about health literacy, we talk about institutional health literacy. Institutions must be ready to give every patient, independent of what education, whatever they come from, to become an informed patient, to make informed decisions. And on a macro level is a society question, I think, and that is even more true in this current situation of the whole world. What is a fun fact is that just beside there is a conference on gas and oil. I think everybody has already recognized it. And in a world where people are getting less and less free, in my perspective, there are some questions. Okay, I think there is taking over responsibility for everybody, not only for health system, but also for other parts of society, can be a change. And therefore, I think SDM could be the beginning of a better development inside of society. So it is also on a macro level a big challenge, and we should follow also here shared decision making. Of course, is it a question of education? Do people really think like doctors? They always say, as you can imagine, I have a lot of discussion with my colleagues in Cologne, in North Rhine-Westphalia, and in Germany. And there's also the argument the patient don't understand. And if you have the talks on this morning, I came a little bit late, but this is really difficult. But, and I love this sentence very much, education shapes the ability to participate in SDM, but the opportunity to participate is created by the healthcare system. And that is again healthcare system, institutional health literacy. We are responsible that everybody is able to follow what he is suffering from, to know his chances, to know his options, and to know how to deal with this and be part of the decision. Education facilitates SDM, and SDM should be not depending on education. I think the last sentence, without careful implementation, SDM risks reinforcing inequalities. And that is really, really true. If people maintain that they're doing SDM, but in reality they are not really doing it, and that is what we're facing day to day in our discussions, then it makes it even worse. You have to implement the whole thing as a process. And this process not only belonging to the patient, is also part the doctors, the nurses, the whole system, on a micro and on a meso level. That is very important, and that has to be understood by all parties. And then, of course, this is what I said in the beginning, that when patients, that is what I also facing. Patient came to me and said, well, Uli, can you take the decision for me? I don't understand anything. Well, that's fine, and it's also okay. As everybody here in the room knows, that the emotional burden with diagnosis and everything which comes along makes it hard to follow the facts and figures and everything. But if I take the responsibility as a doctor to make the decision for the patient, then I have to be aware of, and I should tell the patient that he should be aware of that I don't know his values, that I don't know his preferences, and that is a risk for him. And if he understands that, and if he is admitting that he will also, nevertheless, he will let me make the decision, then it's fine. Then it's shared decision making. If you know the pros and cons of let me make the decision, that is also shared decision making. And therefore, I think it is even more important to be trained in shared decision making, to know what it is really, what is the process behind it. If the patient wants to give me the whole responsibility. And not only on this way, I can ensure that the patient values and preferences are part of the decision process. I think to this process there is no alternative. I think we have a lot of challenges in the healthcare system. I don't know who has followed the last discussion in Germany. We are always, it is too short on money, it's too short of everything, too short. And right now we have calculations saying that in the mid of the 30s in Germany, we have 1/3 doctors which were leaving their profession. And we have a big need of doctors caring. And all these interventions they are practicing in Germany, I'm not convinced that that is of any help. It's only superficial. I think we have to go more into deep, and this is a part of going into deep. STM is maybe the most effective way to take patients' resources into the process. Then it is crazy that we in a healthcare system, we try to optimize everything, but we do not take the patient resources into account. Patients' resources are not used right now, and that makes it really difficult. And when we face that there is 1/3 of the doctors are missing in the mid of the 30s, the only way is to avoid overtreatment. And we have in Germany more or less a calculation that we have 1/3 of interventions are not needed. As I told you just about the patient with the metastasis of the cerebrum, I think we have to discuss even more about interventions. There are also other reasons why people are treated, for example, for hip interventions or knee interventions. We have the discussion in Germany, and we see that in Germany it is 1/3 more than in other European countries. That might be because the Germans are more ill, but I'm not quite sure. So I think we have this challenge, and I think if we don't learn to introduce the patient with all his power into the system, we will fail. And I think I want to make a little a comparison to an earlier times. Only the older here in this room might remember this T-shirt. In the 70s, there were these safety belts were introduced in Germany, and people had really hard to struggle to get used to this security intervention. And what they did, those being more creative, they made these T-shirts. And these T-shirts were for drivers and for by-drivers in a different way. So they had this T-shirt, and if the police came along, they were just passing. Yeah, that's funny, but that is about, but finally, right now, you couldn't earn any money with this T-shirt, because right now, if you sit in a car, after a few meters, you would feel, oh, I feel insecure. There's something missing. Oh, the belt. Then you take the belt. Even if not, the bell is ringing all the time. Then finally, you will do it. So I think STM should be standard and should be standard care like a safety belt by car driving. And I'm pretty convinced that that will change a lot. The potential of STM is big. It will change the whole game, which we are now doing, and will prevent a lot of problems. I will not only make Versprechungen, jetzt fällt es mir gerade nicht ein, will not only give you some good thoughts, pardon? Promises. Thank you, Nico. I will not only give you promises with the missing words. No, I will just also tell you that it is really possible. That is what the doctors always saying. We did a very big project in Germany from 2017 to 21, and that was a very new one that has never happened in the world before. And what we did, we created a program called Share to Care, and we tried to change a whole system, the whole university clinic, this one in STM communication manner. And what we did in the university clinic of Kiel, which is a town in northern Germany, we changed every department of the clinic. We implemented shared decision making. And what does it mean if I say implemented shared decision making? You see it on the right side, there is a training of all doctors. That is what I mentioned before, 4 hours only. Then inclusion of the nurses. They were partly all of them were informed, and partly they were trained. And on the patient side, we made patient decision aids, about 100 different aids to different indications. And there's a general patient empowerment method. And that is, maybe you know, that ask three. Patients should ask three questions. What option do I have? What are the benefits and harms of each of these options? And with which security that will happen to me or not? And that helps. That makes a big difference. So what we have learned is that with making STEM a reality, we could show there's a significant improvement of communication skills in HCPs. We have improved health literacy in less time. The doctors need only 18 minutes before they needed 20 minutes. We have significant rise in perceived involvement, and we have, and that is even more important, significantly less emergency cases compared to other clinics, because the adherence was better, because the patient did better understand their treatment and the way to treat. And now you're ready, I'm ready. So finally, I think there is no alternative to STM, and I think we can, if you like, to discuss the role of patient advocates.
Thank you very much for this amazing presentation. Maybe we'll swap. That way you can use this microphone. All right, so we have lots of questions on Slido, so let me start with the most upvoted one. So sometimes the patient educates the doctor, actually I would say often. How can we as advocates increase the possibility of dialogue with our medical team?
Yes, now it's on. No, okay. Yeah, difficult question, good question, difficult question, since we know that, as I showed you, nurses are trained as decisional coaches. And what we are now trying to is that in Germany, to make it more scientific, educate patient advocates to decisional coaches, and giving them the competence to support patients in the decision-making process. So that is, on the micro level, a very important thing. On the meso level, I think patient advocate groups should discuss with politicians, saying we want this part of shared. We want to make shared decision making happen. That is important to us. It makes so many advantages, and not only for us but also for the doctors. There are some literature hints saying that doctors have less burnout if they work in a STM environment. It's easy to understand. If you imagine you have kids, I have two. And of course, if I can explain them what to do and what not to do, and they are adherent, then I'm also satisfied, not only them. So that could be helpful for everybody. And on a macro level, okay, that has to be a political discussion.
Yeah, thank you very much for that answer. I mean, I can say that when I was in med school, we did get taught about shared decision making, but we were taught that obviously it improves patient adherence and also obviously patient involvement, but we were also taught, and maybe this is just as much a driver, that it is more defensible medicine. And maybe that's a North American way of looking at it, but it means that you have adequately explained the risks and benefits for the many choices that you have, that the patient has. And so it's better medicine, but it's also more defensible medicine. It's more defensible, but doctors, and that is, you have to be beware of doctors. Doctors overestimate the power of intervention. There are so many investigations to that, so many scientific results saying, if you ask a doctor how effective is to do nothing, they say, oh God, we have to do something. If you ask them, how powerful is your intervention, he says, very, very powerful. So that is understandable, partly, but doctors overestimate the power of their intervention. That's a very good document. It's a very good point. I want to ask you what's the role of a nurse in shared decision making? You alluded to it as part of the Share to Care program, but can you tell us more? We have some very good results if nurses are caring about decision process. A colleague of mine, she investigated it, that cuts the time between doctors and patients to a third.
if they are involved in the process, if they have the time. If you follow all these numbers, they say that nurses have 5 times more contact to the patient as the doctor has. That doesn't mean that she has time or he has time. That just simply means there's more contact, and if every contact is with the attitude of shared decision making, then that supports the patient extremely. And therefore it's explainable that this saves so many times, so many resources if the nurses are involved. And it is different. It is difficult in Germany. I think it's in other countries maybe less difficult. In Germany, the nursery is just on her way to a more professional and more effective role.
Yeah, it does vary. I practice both in Canada and in Belgium, and the role of each healthcare person really varies from one country to
Absolutely.
the next. We have 2 questions that I'll summarize into one, which is that should shared decisions also evolve to shared responsibility? So does one evolve or mean the other?
I think if I just would simply say yes, then it's even also true. But I think shared responsibility is also without shared decision making in my belief. If you take a pill in anyhow, if you have any side effects, you will not go to the doctor and say, well, you are responsible right now. So I think everybody's responsible. But with shared decision making, this responsibility is more clear. Everybody is better understanding his responsibility. And therefore I say yes. And that makes the cons in STM.
There's a great question here that where someone asking, how can I empower patients to insist on having shared decision making? It's a great question, yeah.
Oh, but I think I can only answer this in the point of view from a German perspective. And I think everybody can insist. In Germany, finally you have to switch the doctor. That is always what we say, saying, well, take a second opinion, and if you have the feeling that the doctor is not caring about your values, not caring about your preferences, I think finally you have you can't sue him. You just can switch the doctor.
I'm going to blend 2 questions again, but how do we ensure that patients have all the information they need for good shared decision making? And how do they handle the fact that oncologists often say that there's just not a lot of time to discuss all the things?
The second question first. If doctors say they have no time, then you should tell them, then take the time in the beginning a lot more. What we could show that with shared decision making, with a structured strategy, the doctors in Kiel, in the beginning, they need 20 minutes for a decision talk. Within the training, they had 22 minutes. At the end of the training, they had 18 minutes. And the patient were much better informed, and the health literacy was significantly increased. Mm-hmm. So that is so striking. And we have so many information on the power of communication skill, on the improvement through communication skill. We have so many results. I always say, if you were going in a space shuttle and you have all this knowledge about security, which we have about communication, you wouldn't take it into account, and you wouldn't protect the space shuttle. Then you would be in the jail for the rest of your life. In Germany, a doctor is able to treat patients without any training on communication skill. That is crazy. Shouldn't be forbidden. We are just on our way. We are discussing with the German cancer centers whether having a communication skill training is a part of the license discussion for cancer centers. So, but it is I hope it's underway.
Thank you for that answer. We've got so many great questions. Maybe I'll do a couple more. There's someone who's saying that oncologists told me once that it is difficult for them to accept if a patient refuses treatment. Do you have any advice? And I will take this advice because in the ER I had, you have cases of young people with really serious illnesses, and I had a case where a young person refused care. They had metastatic cancer and they would have needed dialysis, but they refused dialysis. And obviously I respected their choice, and we talked at length with the nephrologist, but I had a difficult emotional time with that decision. So I welcome your advice.
I think there's, of course, no recipe to say do it like this. It's
Yeah.
always different. The other question was, how can you assure that patients are well informed? I think it shouldn't be depending on, I don't have to have a class work to do with, and then have to pass a test, and then I'm qualified to do shared decision making. That shouldn't be the approach. I think, of course, I remember a young woman I was treating with acute leukemia, and she had her first transplantation in the age of 16. And then from her sister, actually, she had the bone marrow. With 19, she has a relapse. And then I was responsible for her, and we had a very, very good time. And then all of a sudden she said, well, can I have a little talk to you? And I said, well, let's talk. And she said, I can't stand it. I've done it once. I can't do it again. But I'm afraid to tell my father. I'm afraid to tell the other doctors. And then we had a kind of an alliance. And I said, well, if I can, I take care of you, and I will talk to your parents, to your father. I will talk to the other doctors. And this is always different. But if you don't believe the patient, and you have to be aware that it is limited. You can do as best as you can, but in several cases, patients don't want to. And we have to accept that.
Yeah, so it's
And
difficult, but accepting it.
Now I come back from emotional to scientific. There is a scientific study in the Netherlands. They have done, in a certain area, they have done shared decision making in one group, and the other group treatment as normal. And that was in geriatric oncology patients. And what they could show that after a year, in both groups, the same number of people were living, still living. But in the one with shared decision making, they had a third less treatment.
Interesting.
So that says a lot of.
Yeah. One last question before we wrap it up. So there's many, but I chose this one because I think it's a bit different. How does shared decision making differ in cancer versus other chronic diseases? I feel like deciding to start an antihypertensive is not quite the same as deciding to go on chemo. Both are important, but in different timelines.
Well, I think there is no difference.
Interesting.
I think there's an investigation showing what's about patients' burden with different diseases. And as some might assume is, if you have only lymphoma, then the burden is not that high as when you have lung cancer or whatever. In the end, what came out was the burden is not depending on the disease. And I think in this respect, I would answer that it is in every situation it is the same important, since in every situation you can treat or not treat.
True.
And I think, and therefore, I see not really a difference. Of course, the challenges is different. If you have a young patient, 25, suffering from mild lymphoma, but I would state again, it's no difference.
The principles hold, yeah. Well, before I open the floor to thanks, I just wanted to give you one piece of positive news. Maybe you can add it to your map of where shared decision making is done in Europe. Someone in the audience said, I got news for you. My complete cancer treatment was done with shared decision making at the Hirslanden Clinic in Bern, Switzerland. Further, they are leading in psycho-oncology. So that could be an interesting little point on the map.
Thank you so much for this advice. Actually, we are in discussion with Hirslanden because they wanted to implement. What I meant is, I think there are a lot of my colleagues are trying to make shared decision making, and they do it as best as they can. What we are talking about is implementation of a process, and that is a different thing. And it shouldn't be by chance that you meet a doctor who is trained in shared decision making, and then you are lucky to have this process. It should be part of the normal standard care.
Please join me in warmly thanking Jens for his great insights. Thank you so much.
Thank you for inviting.